You're tuned in to Women in America, the podcast that dives deep into the issues shaping gender equality in the U.S. and beyond. Hosted by Pari and Eve, public health professionals by day, content creators by passion, we bring you expert insights, compelling stories, and actionable strategies to push the fight for equality forward. This season, Rights at the Crossroads unpacks the intersections of reproductive rights and gender justice in today's America.
On this episode of Women in America, we chat with physician assistant Nikki Vinckier about EMTALA and Trump's recent removal of guidance requiring hospitals to provide emergency abortions to pregnant people. Let's dive in.
For your Take Back the Trust, can you remind me what you do through that?
Yeah, so it's called Take Back Trust, which is a direct-to-patient education and empowerment platform. And the goal is to provide tools for patients to help them navigate their reproductive healthcare journey. So I'm an OBGYN physician assistant. Over the last several years, I have friends that text me all the time with various questions of, hey, what should I do for this? What should I do about this? My clinician told me this. Is that true? What do you think? Kind of these curbside consults and second opinions. And then in addition to that, after Roe fell, I got a lot more questions. And after we lost the election in November, I got inundated with friends sending me text messages, really asking reproductive health care questions. And I thought to myself, they've got access to me, but the bulk of women don't have access to a clinician in their speed dial. I don't have access. Yeah. And so it felt like people were just answering questions willy-nilly on stories on Instagram, but there was nowhere where it was housing this information. And so that was the original intent of Take Back Trust, was to kind of house some of the concerns about the landscape that we're in, how it relates to reproductive health care from an actual clinical standpoint of it, not necessarily the policy landscape of it, and how to navigate your upcoming appointments to the best of your ability. So we have a provider visit planner, so you can strategically ask and be guided into good questions to engage with your healthcare provider better. So it helps teach you things like, if you have embryo that are stored in red states, it might be a worthwhile thing to move it. And here's what you should be considering. If you have an IUD that's due for a replacement in the next year or two, here are different ways and strategies which you might be able to get it approved sooner to replace it through your insurance. Here's IUD pain management strategies right before they came out with the new update just last month in May. So it kind of really tackles a lot of clinical questions that people have tied within the landscape of the ever-changing, not great abortion and reproductive health care.
That advice about how to get your IUD before it's expired would have been so helpful to me in the first Trump administration, because I still had 2 years left on my IUD at the time. And I went to my doctor and was preemptively, please replace this thing. And she was sorry, no. Luckily, I was fine throughout the rest of that, and I was able to get it changed. But we didn't know what was going to happen. And if I want to, I should be able to get it changed.
Correct. And IUDs are far more at risk right now than ever before. And the reason why is they're at risk with the fetal personhood language. So you still ovulate. I'm sure you know this, but just for all those who are listening, you still ovulate with an IUD. The bulk of people do. And so the concern is that you still do have risk of a fertilized egg. It just won't implant into the uterus. And the anti-abortion movement is considering that as, life begins at conception, which would make it so that they don't like IUDs. So that's probably the first level of contraceptive that they're going to kind of come for, just for the, people watching. I know you know this, Eve, but it's definitely, if you're on the brink of getting a new IUD and you like an IUD, I think that that's an urgent thing to replace.
Yeah. I do want to get into EMTALA because that's what has been all over the news. But before we do that, I feel like a lot of people don't understand what personhood laws are. So since you brought that up, not to put you on the spot, but you're very comfortable talking about these things, would you mind explaining what a personhood law is? We also were talking about moving embryos and IVF, and that links back to, what happened in Alabama. So what are these personhood laws that are forming the basis of the anti-abortion movement?
Yeah. So the first time we really saw this pop up was a few years ago with the Alabama Supreme Court ruling over IVF, where there were destroyed embryo that they considered as humans. And so they essentially essentially gave full rights to these embryo as people. And so what that kind of laid the groundwork for is a multitude of different things. Number one, it puts so much at risk because it kind of sets the basis that life begins at conception. So like we talked about, it puts IUDs at risk. It puts IVF in the way that it is done and designed at risk, because what they really don't like is the development of multiple embryo with the implantation of only one at a time. But if you know anything about IVF, numbers and attrition rates are astronomical. So for example, on average, let's say they'll gather 15 to 25 eggs and then they'll fertilize that. And then, it's like with every step in the IVF process, you lose. And so the goal would be that out of those 20 to 25 eggs that you fertilize, maybe only 3 to 5, if you're lucky, you're going to make it to a graded embryo that's worthwhile to transfer. And so IVF can be so expensive, so invasive, all of the things that doesn't make sense to do one at a time. And so fetal personhood, how it relates to IVF is really a challenge. But how it relates to some of these abortion restrictions is that they're giving an embryo the same rights as a mother, because they're saying life begins at conception.
Yeah. And what that means in practice outside of the IVF example is, I think even before the Supreme Court case in Alabama happened, Georgia passed personhood law. I think they were the first state in the country that in their tax law said embryos are considered people that you can claim as a dependent on your tax return. So if someone is pregnant, they can claim the embryo or the fetus on their tax returns as a dependent and get their tax credit for that. And what kills me the most about this whole how this whole personhood thing rolls out is that a lot of the legislators in Georgia were asked about crazy scenarios if they're considering embryos people, can a pregnant woman drive in an HOV lane, blah, blah, blah. And they were like, oh, we didn't think about that. They didn't think about it.
That's the problem, is with all of these laws, there's not enough understanding of what the actual medical implications of these are. So we'll talk obviously about EMTALA quite a bit, but the concern is in terms of treating the mother separate than treating the baby. The only instance where that is actually the case is Adriana Smith right now in Georgia. Aside from that, if you are treating the mother, ipso facto, you are treating the fetus, right? The fetus doesn't exist without the mother. And so this ridiculous concept of separating them and treating them separately, aside from Adriana Smith, does not exist. And so I think that's the interesting thing, is that language, fetal personhood, is not an actual medical term. That's not anything that's ever taught or thought about. It's just really they're nuancing this kind of caveat to, put IVF and abortion and contraceptives at risk.
So I actually think this does lead into the EMTALA discussion because, if someone enters an emergency room with a pregnant person enters an emergency room needing care, what Trump just did, rolling back the guidance on EMTALA, already complicates things. But if there were personhood laws in that state, it would make it even harder for doctors to understand whether EMTALA applies or not. I have my understanding of EMTALA, but instead of continuing to say this acronym, perhaps you could define it for us and tell us what your perspective is on EMTALA.
Yeah, so it's the Emergency Medical Treatment and Active Labor Act, and it was put in 1986. So it's been in place for decades. And the goal is essentially that hospitals need to stabilize a patient prior to transferring care, and that you need to provide appropriate care to a patient regardless of their ability to pay, is kind of what it started as.
Because hospitals were dumping patients, right? They were oh, insurance, so we are not going to stabilize you.
It was really originally about payment.
How do you take the oath to be a doctor and then do that?
Because the challenge is that those who take the oath to be the doctors aren't the ones who own the hospital most often. There's a huge issue here between doctors is you're paid for the treatments you provide. And at the end of the day, hospitals are businesses. And I think that that's one of my biggest issues is I think often doctors are the ones blamed for all of these things when I think this is a larger systematic issue. Because yeah, doctors went into this to help people. Of course, they don't want to dump patients either, but I don't know back in the 80s what the advice they were getting or the support they were getting from their hospital system was. And so, yeah, it was originally made for that. And then that has always been understood that also includes immediate abortion care. And the most obvious cases of that is like ectopic pregnancies, right? Or premature rupture of membranes. Now, when that got put in the 80s, and Roe was in place since 1973. So Roe preceded EMTALA. And then when Roe fell in 2022, when Biden was president, the Biden administration put behind EMTALA a guidance that said, hey, this explicitly covers emergency abortion care, which never did anything different to EMTALA. Guidance is just like mere suggestion and like backing, if you will.
Like a reminder.
It was a reminder of, hey, EMTALA is here and like, hey, clinicians, we have your back if you perform an abortion, specifically targeted to the states that have, abortion bans in place. So the biggest issue and misstep that has happened over the last week is that the Trump administration pulled back and revoked that guidance. They said that guidance is no longer in step with our administration priorities, essentially. That does not mean that they told hospitals that they can kill women and let women die. EMTALA in and of itself has remained unchanged. It's just that guidance, that like additional security of the like standing behind EMTALA that's gone. And so clinicians should still be doing the same thing that they were doing before with EMTALA. And the concern is kind of about how some of these things were framed is A, if you're a patient that is hearing people say like the hospital and the ER is going to just let women die, you're not going to want to go to the ER. So if you have, severe abdominal pain, you're going to think to yourself, oh, they can't do anything for me anyway. And so you delay care and going. So that's hugely dangerous. And then you sow tons of doubt into the healthcare practitioners that also, unfortunately, are receiving the news and information from social media also. So we don't have like great governing boards that are providing us up-to-date information and guidelines and recommendations. So that's one of the biggest issues is that there's nowhere as clinicians that we're getting guidance rapidly. And everything takes a long time to kind of come down the pike. And so when you sow doubt into the system from a clinical standpoint on both patients and providers, you lead to more hesitation. You get concerns, obviously, that those moments of hesitation are what can be really deadly. And so that's been kind of some of our strategic management of the conversation this week of how do we tell patients if you are in need of emergent care, you need to still go to the emergency room, and clinicians, if you just keep doing what you've been trained to do. It's a really difficult landscape. And it was a nice thing to have that guidance to kind of back it. But that guidance didn't actually protect you all that much more than what EMTALA does.
The way that I see the guidance, if I can simplify it to like the lowest level, is like, if you don't like spicy things and I remind you to not put 5 habanero peppers on your sandwich, okay, that's like a nice reminder. But like, you probably shouldn't put 5 habanero peppers on your sandwich anyway, right? So like me telling you that is like a nice courtesy, but it's not needed for you to know not to do that.
Correct. And I think that there are other ways in which we can try to get that same, guidance and comfort to clinicians. And I think that this should be something strategically that we're doing within the movement is really applying pressure to hospital systems, especially those in the South, governors, especially like an Andy Beshear in the South, in a state with an abortion ban, to come out and put a state level EMTALA guidance in to be like, hey, we do have your back, right? Because the biggest concern about that guidance being gone is clinicians losing that feeling of like someone has my back. And so how do we make them have that feeling again? How do we actually provide substantive support? And that's going to be ERs putting very clear guidelines on exactly what they support in place. So before it happens, right? This cannot be a chase your tail. This cannot be a patient comes in and you have to call the attorney before you can provide care, right? So that's kind of part of what I think we really need to focus on from a movement level is, okay, is and was great. And EMTALA is not all covering. Like EMTALA still does not cover all of the bases. So what can we do on a, ground level and state level that does provide more support? And we know that hospitals are businesses, like I said, so we can put pressure on them. They have a board of directors. They are in service to the community, and it doesn't feel like that often because they're such conglomerates. But we need to be applying pressure to them. We need to be applying pressure to our state legislators, to our, leaders on a local level, on a national level, so that they're also applying pressure to those hospital systems as well. We need to be pushing our governors to put out laws and protections as well. I mean, it's from a systemic standpoint. If they're going to say put it back to the states, then let's
the state.
go, let's go.
I have to say, when you and I were frantically texting back and forth when the EMTALA news came out. And I have to say, one thing I was surprised to hear you say was what you just mentioned, that there isn't clear guidance from hospitals to the providers on what to do in these situations. And at first I was alarmed when you shared that, a lot of providers are getting their information from social media. But, when I thought about it, I was like, that is no different than any career industry, but didn't have to, right? So why is this guidance so weak from hospital administration? What is the reason behind that? Do you know?
I don't know. That's a good question. I think the social media thing is just kind of a part of the way in which social media has developed to be so rapid. That's across the board, like you said, right? Kobe Bryant's wife found out that her husband died in a helicopter crash from the news.
Oh, she found out?
I think so. Maybe it wasn't her. Maybe it was the other family members of people on the helicopter. But there were people who found out that their family members had died on a helicopter crash from the news, right? So this is everything across the board. And I think back to when Dobbs came out, and I was in clinic that day in Michigan in a swing state where we had an abortion ban on the books from 1931. Dobbs had come out, and I'm in between patients. I walk out. I know that this has happened. And I'm like, what am I supposed to talk to patients about? How am I supposed to counsel them? Some of these states don't even allow you to talk about abortion, obviously, let alone provide it. And so I'm in between patients, gonna go in late to my next patient being I don't even know what I can say in that room right now, because there's nothing that comes out simultaneously with the news that's guidance behind it. It was crickets from our governing board. It was crickets from the governor. It was crickets for days. And the first thing that I saw was a social media post from our county prosecutor, Karen McDonald, who I hope is going to run for our attorney general because I love her, saying, we will not prosecute a provider who talks about abortion or provides abortion care in our county. And I was like, great. Walk me to that room, continued my counseling the way that I always do. So that's the part that really concerns me is I got that news from Instagram and I'm like, okay, I guess I'm insulated because my county prosecutor won't prosecute me down. There's nothing that's the problem.
But so I want to be clear in that example. Yeah, you got the information from Instagram, but it was from a public official, a very reliable source.
Correct. But as in PA, nobody ever taught me in PA school, hey, here's who you need to look to be talking about illegal things that you could or could not be doing. In my mind, I know enough about the landscape that I'm okay, I think if my county prosecutor says I'm good, I'm good. But I don't know.
So this is why, going back to your point, there's this chilling effect that we use that term all the time, how the Trump repealing his guidance does not change the actual law that hospitals are required to stabilize patients, but it does create confusion with providers on if they even take a split second to think, do I need to call a lawyer before I provide this treatment? That could cost someone's life. But
or realistically, more than a split second, if they call the attorney, that's 10 minutes, 15 minutes, right? That's a long time in patient care.
Yeah. That's the scariest part. But I take your point that it's not on the doctors, it's on the hospitals to provide timely guidance and resources. But I think the point we want to drive home in this is that the law didn't actually change. Providers should still be providing stabilizing care. The guidance was a suggestion, a cherry on top, but it was by no means
it was a weighted blanket for clinicians, you know?
Yeah.
Like it felt nice and it's good, and especially in the South where it's very complex. But yeah, it wasn't substantive enough.
Yeah. So I think this has been very productive. If people want to find you online, where do they find you?
Yeah. I also do repro content just like you guys. We have a nice little symbiotic love affair. So I'm Nikki Vink. You can find me there. And Take Back Trust is Take Back Trust on Instagram and TikTok. And yeah, I love having these conversations. I love getting to do this with you, Eve. It's always so nice to be able to have, strategic conversations with other people within the movement, outside of the movement, even just, I talk about it as like playing chess, right? The other side is really good at playing chess. And so sometimes it's kind of fun when you're talking to somebody else who's like in the same movement. It's just like practicing chess, right? Like we're just like getting to play it together and like learn other strategies and thoughts. And like that part is really cool to me, because then when I actually have an opponent that I want to beat, I'm going to be better because I have better chess strategy, And so like I really like that.
Nikki, I feel like there's some kind of social media campaign here around like learning to play chess players or something like this. So offline. I like it.
Thanks for tuning in to this episode of Women in America. Despite Trump's attempts to sow chaos, EMTALA remains the law of the land. Hospitals are still required to provide life-saving care to anyone experiencing a medical emergency. Tell a friend. If you enjoyed this episode, share it with your network, and don't forget to subscribe wherever you get your podcasts. For additional resources, follow us on social media at Gemma_talks. See you next week.